Good morning, Lexington, and thanks for tuning in. Today, our first story revolves around a young woman who had to go through an emotional journey in order to overcome the faults of our public health care system.
Ms. Kelly Thompson, a local Lexington resident, is 24 years old and has recently been diagnosed with osteoarthritis. She planned to undergo a corrective procedure to have a titanium rod and screws placed in her hip. It's common practice, but it went terribly, terribly wrong. Ms. Kelly met with us earlier last week to talk about her story.
Hi, my name is Kelly Thompson, and I'm here to talk to you about my story about how I was diagnosed with osteoarthritis. When I was born, a couple years later, the doctors diagnosed me with hip dysplasia. This disease was, obviously I had no idea what it was when I was 4, but all I knew is that I was put in this big body cast and I couldn't go run outside and play with my friends, and it was terrible and I had to wear it for a whole year. But when I was 5, the doctors finally let me take it off. But I still had this weird hip pain. I still hurt when I walked. It still hurt when I crawled. I don't know, but my mom would just always give me Tylenol and then it would go away, and I just kind of went along with it the rest of my life. In high school, when I hit puberty, obviously my hips changed a little bit and the pain got worse. I ended up running in high school to try to make the pain better, but nothing ever seemed to work. I met my husband in high school and we were married when I was 19. And we love to be active. We love to be outdoors. We have a dog. It's a Great Dane, and you have to get him to run in order to calm him down. And so we would go run around the neighborhood, take him to dog parks. We like to go swimming a lot, but still the pain would never go away. My husband would always make fun of me because he said, I had such a low pain tolerance and I couldn't do anything, but he noticed that I couldn't even run like 2 miles anymore without having to stop and sit down, or I'd stop crying. It started to get really bad. I'd wake up in the morning and the pain would be there for probably around 30 minutes or so, and then it'd go away. But then later that day when I'd go on a run, the pain would be increasingly worse. All of a sudden I'd have to stop and sit for a while. I ended up going to the primary care physician, and he gave me a cane to use. This was terrible. Who wants a cane at 22 years old, right? But I used it and it was fine. And then a couple years later, I realized that I was not using this cane just for extra stability or when I was running and my hip hurt. I was using the cane as soon as I got out of bed to walk to the bathroom or to walk to the kitchen to get a bowl of cereal. I was using this cane to walk. Without the cane, I couldn't even walk. That's when I decided I should go back to my primary care physician, and he did end up diagnosing me with osteoarthritis.
Osteoarthritis is a disease of the synovial joint that is progressive, non-inflammatory, and is commonly found in the older populations. While it is common in older populations, being older is not a risk factor. In osteoarthritis, there is new tissue formation resulting from cartilage destruction. This eventually leads to soft, less elastic, and less resiliency with the heavy use. This destruction is too fast for cartilage repair to keep up. As the disease progresses, cartilage becomes thinner, and osteophytes create bony spurs on the joints, and subsequently results in pain and a loss of range and motion. Synovitis, seen in these changes, causes the pain associated with osteoarthritis. Causes of osteoarthritis include trauma, such as fractures that cause uneven stresses on a joint. Mechanical stresses, including repetitive activity, obesity, and joint instability, also contribute to the development of osteoarthritis. If a patient's joint is unstable, it means that his or her joint is lacking support system from its surrounding structures, further increasing the amount of stress applied to the joint. Inflammation, drug therapy such as steroids, hematologic disorders, and skeletal deformities can also lead to the development of osteoarthritis. There are no systemic effects of osteoarthritis, but there are joint and deformity manifestations. Joint manifestations are the most common and are usually why patients seek help. The joint pain is common in the morning but usually subsides within half an hour, but usually increases with activity. This pain is usually resolved with rest at first, but as the disease progresses, pain is harder to be relieved by rest and causes disability and the loss of function. Soon everyday activities become unbearable without medication. Joint stiffness and crepitation are also common symptoms of osteoarthritis. Heberden and Bouchard nodules are associated with osteoarthritis and are usually hard, red, swollen, and tender. Patients with osteoarthritis of the knee usually have crepitation, a bowed leg appearance, and may have an altered gait.
In order to diagnose osteoarthritis, the first step would be to do a thorough family history and a physical examination. After those are complete and you think the patient still has osteoarthritis, the next step would be to do radiologic studies of the involved joints. The most common are CT scans, MRI, X-ray, and bone scan. CT and MRI detect early joint changes, and X-ray confirms your disease and staging the progression. As OA gets worse, the X-ray will show the joint space narrowing by bony sclerosis and osteophyte formation. A bone scan is the last type of radiologic study done, but is not as common as the other three. The final diagnostic test is a synovial fluid analysis. This helps determine between this and other forms of inflammatory arthritis diseases. The synovial fluid during osteoarthritis is clear and yellow with little to no signs of inflammation. There are no laboratory tests to mark osteoarthritis. There is no cure for osteoarthritis. Treatment focuses on managing pain and inflammation, preventing disability, and maintaining and improving joint function. Non-pharmacologic therapy is recommended. The first method is rest and joint protection. It is important to balance activity and give time to rest. If you rest the affected limb during periods of acute inflammation, maintaining the limb in a functional position with sprints or braces, it is more likely that you will not have pain. Do not immobilize your joint for longer than a week because it increases your risk for joint stiffness and inactivity. The patient may need to modify usual activities to decrease stress on your joints. Finally, you may need to gather assistive devices for your patient, such as a cane, a walker, or crutches. These can help decrease stress on arthritic joints. The second method is heat and cold appliances. Heat is used more often than cold. It is used especially to help for stiffness in your joints. Nutritional therapy and exercise is also a big treatment plan for osteoarthritis. If your patient is overweight, a diet may be gathered to help the patient lose weight and help their joints not have as much stress. Exercise is also a fundamental part of treatment. Aerobic conditioning, range of motion exercises, and specific programs are ordered. Finally, complementary and alternative therapies are used for non-pharmacologic treatment. This is good for patients that have failed to find relief in other treatments. Acupuncture helps decrease chronic pain. Yoga, massage, guided imagery, and therapeutic touch are other forms that are used. For pharmacologic treatment, there are several options. Mild to moderate osteoarthritis usually is ordered Tylenol. 1,000 milligrams is given every 6 hours. You do not exceed 4 milligrams in 24 hours. There is also topical agents such as capsaicin or Zotrix. It blocks your pain and locally interfering with substance P. It is responsible for transmission of pain impulses. There is also hyaluronic acid, which is an injection given 3 times a week. For moderate to severe osteoarthritis, the patient would most likely take NSAIDs. These block the production of COX-1 and COX-2 inhibitors. This causes an increase for GI bleeding. You can also obtain intra-articular injections of corticosteroids. These may be appropriate for the patient with local inflammation and effusion.
A hip replacement is a surgical procedure that involves replacing diseased and/or arthritic hip joints and replacing them with artificial counterparts. Many times, a hip replacement is ordered to reduce pain and increase the function and mobility of the hip, as well as improve the patient's ability to perform independent daily activities. Hip replacements are indicated when patients present clinical manifestations of osteoarthritis, rheumatoid arthritis, osteonecrosis, which is a vascular necrosis of the bone, fracture, and/or bone tumors, which have limited the patient and have caused the patient intolerable amounts of pain that have not been relieved with prior treatment methods. Age is no longer a factor in how well a patient will tolerate a hip replacement operation, as nowadays the artificial parts are made substantially enough that they can withhold a greater amount of stress that is put on them by more younger and active patients. Hip replacement surgeries are contraindicated in patients that have chronic muscular diseases, patients that experience muscle weakness or spasms, or patients that are susceptible to infection. Recovery after surgery can range from 3 to 6 months, and potential complications involve hip dislocation due to improper positioning, inflammation due to irritation of the artificial counterparts, infection, blood clots, and increase bone formation around the normal parameters of the bone. After surgery, it is important to incorporate exercise in order to promote flexibility and mobility in the newly founded joints. Although most doctors will recommend against being involved in high-impact activities such as basketball, jogging, and tennis, many doctors agree that being involved in exercise classes that promote proper range of motions are a good option for the patient recovering from hip replacement surgery. Other activities that promote a better quality of life include walking and stationary biking.
So I went to the specialist and they decided to do more tests for my hip replacement. After the test results came back, they discovered that I have bone cancer and not osteoarthritis. This is crazy. I guess I'm ready to get this started and get the treatment undergoing so that I can put this behind me. Never did I ever expect that I would get bone cancer.
Chemotherapy is the mainstay of cancer treatment. It is also the most toxic drug group because in order to cure the cancer, 100% of the cancer cells must be killed, which harms the body's normal cells as well. The goal of chemotherapy is 100% cancer cell death with limited cell injury, which is why it is administered in rounds. If a patient received chemotherapy every day, the patient would die because the drug is so toxic. Administering the drug in rounds allows a little bit of time for the normal body cells to recover, and ideally not enough time for the cancer cells to recover before the next round. Chemotherapy also decreases the patient's red blood cells, white blood cells, and platelets. So it is important not to give the next round when the patient is at the nadir of treatment. Because chemotherapy is such a toxic drug group, there are several side effects of undergoing treatment. Every patient handles chemotherapy different, but there are some normal toxicities that every patient will have. Nausea and vomiting will occur only a few days after the first round. 1 to 2 weeks after, the patient will experience diarrhea, alopecia, and bone marrow suppression. There are 3 major complications in a patient with bone marrow suppression: neutropenia, erythrocytopenia, and thrombocytopenia. A patient who is neutropenic has a much greater risk for infection, so they need to be very careful about being around people and being in public. A patient with erythrocytopenia becomes very anemic, meaning they are very weak, fatigued, and have a decreased activity tolerance. A thrombocytopenic patient has an increased risk of bleeding, so the patient must be extremely careful with daily tasks such as flossing and shaving, because if they were to cut themselves, they could bleed out. Chemotherapy also injures the digestive tract, so the patient will experience stomatitis, which occurs only hours or days after the first round. Stomatitis is inflammation of the oral mucosa, which causes very painful ulcers in the mouth, along with inflammation and infections of the mouth. It can also lead to trouble eating because it is so painful for the patient and can cause heartburn if the esophagus is affected. Chemotherapy also affects the reproductive tract. It will destroy the developing fetus and germinal epithelium of the testes. Thus, women should not get pregnant before undergoing treatment, and males should consider sperm banking, as chemotherapy may cause infertility. It can also cause an excessive level of uric acid in the blood, which leads to cell death and destruction of DNA. Extravasation is a very dangerous adverse effect of chemotherapy agents, if not administered correctly into the vein. If the drug leaks out of the vein, it will destroy the surrounding tissue, which could lead to gangrene and amputation of the extremity. Although chemotherapy is used to treat cancer, it is also a carcinogen. So the treatment for one cancer could lead to the development of a new one. Lastly, chemotherapy is so hard on your body that it can lead to organ damage, such as the kidneys, lungs, central nervous system, heart, and peripheral vascular system. As you can see, chemotherapy is extremely toxic to the body, and the patient should only undergo treatment if absolutely necessary.
The United Kingdom has a government-sponsored universal healthcare system called the National Healthcare Service, also called the NHS, that provides public healthcare to all permanent residents, which is about 58 million people. The NHS is funded by all taxpayers and is free at the point of need, meaning that there are no fees collected at the point of service. Like the current U.S. healthcare system, the NHS has its origin in the years immediately following World War II. It is essentially a healthcare delivery system that combines payer and provider under the control of central government with funding derived from general tax revenues of central government. In the NHS, services are also provided on the basis of clinical need and without regard of the ability to pay. Also, due to the way it is funded, the UK government spends a good amount of money on preventative medicine, making efforts to keep its population healthy so that the need for more expensive treatment later on might be reduced. In a recently concluded Commonwealth Fund study, which looked at the 5 areas of performance: quality, efficiency, access to healthcare, equity, and healthy lives, the United Kingdom ranked ahead of the United States, which ranked last. The UK also has a private healthcare sector where healthcare is acquired by means of private health insurance. The public has the option to buy private health insurance, however, this is usually funded as employer-funded healthcare or is paid directly by the customer. Most of the healthcare insurance is distributed by the NHS, where only a small sector is distributed by private insurance companies. Beginning in 2000, reforms were proposed to improve the quality and availability of healthcare services provided by the NHS. In 2002, further reforms characterized by decentralization and privatization were proposed and implemented. As part of this initiative, geographic areas within the United Kingdom were outlined as a primary care or trust, or PCT. Each individual residing within the geographic area of a PCT selects or is assigned to a primary care physician who oversees and coordinates the patient's health care. Primary care physicians may join with other physicians and professionals in practice and may operate their own clinics and may perform same-day surgeries in addition to diagnosis and treatment. The PCT then reimburses the primary care physician at an agreed rate. The PCT makes the United Kingdom system very different from the United States. Also, U.S. healthcare sets age and income requirements, which include Medicaid or Medicare on public healthcare coverage, whereas UK made public healthcare accessible to all UK permanent residents by making it free at the point of need. Since UK's healthcare is open to all, it often experiences delays to those accessing care and lacks some of the most advanced technologies. The UK has relatively short waiting times for basic medical care and non-emergency access to services after hours, but has longer waiting times for specialist care and elective non-emergency surgeries. An initiative of central government to convert to electronic healthcare records has been significantly delayed and is considered over budget, which raises concerns over privacy and security.
So turns out I don't have cancer. I still just have osteoarthritis. This is crazy. I'm so mad at these doctors. I don't understand why they would make me go all through these tests and tell me that I'm going to get a hip replacement. I'm already scared enough, and then they look at the wrong biopsy and say that I have bone cancer. I went through a whole round of chemo. I was losing my hair. It was terrible. And then they come back and they're like, "Oh, I'm so sorry. We looked at the wrong biopsy and you actually don't have cancer." I don't know what I'm going to do now. I can't get my hip replacement because my immune system is so weak. I don't know. This just put me so far behind.
There is currently already a barcode system within healthcare. It is initiated upon admission when patient information records such as insurance history and current condition is saved under a barcode specific to the patient. Before any care is provided, this barcode is attached to the patient via an armband. Throughout care, the barcode system is utilized to confirm the correct patient is being given treatment, whether it's at the pharmacy, administering medications, or specimen collection. Another benefit of the barcode system is being able to efficiently track the patient's care, medications, lab results, and diagnostics throughout their hospital stay. However, for some reason, some healthcare facilities do not place barcodes on the actual X-ray scans. This makes it easy to pick up the wrong scan for the wrong patient, which has happened in this case. The patient received the wrong care, which can be lethal if not necessary. After this incident, we see the need to add barcodes to the actual scans. The healthcare provider will have the scan the patient wristband and the X-ray scan to confirm the correct interpretation and diagnosis will be given to the correct patient.
So even though new and innovative ideas are underway, it's still important that you as the patient are involved in your treatment as much as possible.
We encourage our viewers to be involved in their plan of care and ask questions and make sure that you understand why you're being treated.
So thanks for tuning in to our morning newscast.
And have a great day.